My name is Jerry Hesch, and I'm with the Hesch Institute in Henderson, Nevada, very close to Las Vegas. And this is a very interesting case in a 47-year-old male. And the name of this case is lateral foot pain in a marathoner who quit running the past 2.5 years, failed prior diagnosis, failed treatment. This is part 1 evaluation at the Hesch Institute. This will be a fairly brief video. I have a home office. Welcome to my home. And Ken, if you would walk in a straight line towards the piano, please. So I'm only going to focus on his feet. What you'll notice, if you look at the back of the heels, there's very little movement, very little side-to-side movement. Those feet are very rigid. He neither supinates nor pronates. And that is congruent with what we find with our hands-on evaluation. So here's a better view. Incredibly rigid feet. Truth be told, although he walks in a very straight line and you see very little transverse plane mobility, very little frontal plane mobility in those feet, truth be told, he also has very limited dorsiflexion. So we'll stop looking at his feet here. And would you lie on the table, please? Ken is a pilot, still works for the government, was in the military. He and his sister used to run marathons together up until 2.5 years ago. The mode of onset for this injury was somewhat sudden in that during a run he suddenly felt some discomfort in the right lower extremity. However, I am going to suggest that it was long in the making and it's more of an overuse syndrome. And I'll try to illustrate what I believe to be the cause. Now, of course, this filming is the evaluative portion, so after the treatment we will find out if we can make some impact. I'm sure that the camera won't capture everything. I'm going to do my best to stay out of way of the camera. His feet are remarkably rigid. The amount of dorsiflexion is perhaps 5 degrees, very close to neutral. He should, per his body type, have 15 degrees of dorsiflexion, perhaps 20 degrees. I'm sure that he has adequate plantar flexion. The subtalar joint is extremely rigid. I'm trying to abduct the calcaneus. I'm sorry, that was adduction. I'm trying to abduct the calcaneus. There's no movement in there. I grab the heel very forcefully and I'm pushing the other direction. There's just no movement. Pushing him into inversion, there's no inversion. This is a very, very rigid structure. And now I'm going to test eversion. There is no eversion. There is no superior glide at the lateral malleolus. The same can be found on this side, but the one difference, interestingly, he grades strong on this side in the peroneals. They're now called fibularis muscles. And on this side, he grades a little bit weak, slightly. Very strong individual here. The left hip, if I test internal rotation in this context, I can roll the leg into about 30 degrees. And with overpressure, you can see that it has additional movement and it has a strong recoil. On the right lower extremity, he's laying on his back. I can only take him into about 10 degrees and there's considerable stiffness. I can bring him into what looks to be 15 to 20 degrees, and then when I try and overpressure it, there's very little movement. So I believe that restriction of hip rotation maybe preceded or maybe acted in concert with the rigidity in the foot. Now the rigidity in the foot is actually greater than the rigidity in the left because the right cuboid does not have any motion. I'm trying to test superior inferior glide mobility, and midfoot is very, very rigid. I was able to produce a little bit of cuboid motion on the left side. What I'm suggesting is that as he would fatigue while running, the right lower extremity would progressively externally rotate. I'm also suggesting that that external rotation is mandated reflexively such that he cannot consciously override it for very long. He might be able to do so temporarily, but in the context of running lots of miles like the marathons which he used to run, there's a point where that's just not going to override. And I think maybe, and I can be wrong, and I'll surely accept and mention if I am wrong, if we can discern that, but I think this significant restriction in the right shoulder may be part of the root of this problem. The right AC joint does not move. Extremely rigid. This shoulder is very forward in relationship to the other. Now I can't show you the relationship of both at the same time. I'm preserving his privacy by not including his face. But if I use this ruler, very, very crude mechanism here, that is approximately 13 centimeters. If I look at the other shoulder, there's a considerable distance between the acromion and this device, and I come down to 11 centimeters. And I'm sorry, let me flip that over. Yes, that is correct. Okay, so there is a difference of almost an inch. Looks to be more at a glance, but that's what I measure with that device. And the other side, the left shoulder girdle, is far less rigid. When I do this springing, I'm actually springing at a 45-degree lateral and inferior, and it's very easy to scoop this. You can see all that excursion, and when I bounce it, when I spring it, it bounces, recoils, and there's a final recoil if I did it correctly at the end, and there is. So here's the plan of attack, and I have screened the rest of his body, and he has had an extensive workup, several visits including neurology with nerve conduction, EMG, MRIs to the feet and to the low back, lumbar evaluation. He has seen several podiatrists, had orthotics, undergone physical therapy, chiropractic care, and I may be missing things, but it's been fairly extensive. He's very good at research, and he's done his research and tried to resolve this condition. So I'm going to stop filming now. It's going to take me at least 10 minutes to treat him. And I hope that when we come back and film, which we'll do regardless of results, it is my hope that we have feet that are less rigid, subtalar joints that are mobile, talocrural or ankle joints that are mobile, and I hope that the fibulate glides superiorly very readily, cuboids are free, even midfoot mobility is improved, and I hope that right hip will internally rotate then freely to at least 30 degrees with a softer end feel, and that right shoulder girdle will have much more mobility, especially at the AC joint. So I'm going to stop filming now. We will come back and film a post-treatment. Thanks very much.